So we'll talk a little bit about some more hand cases, but soft tissue focused. And so I pulled some cases that actually at UCSF we have a really good relationship in the orthoplastic hand team. And this is actually a patient that was consulted by the ortho hand team initially. So this is a mid-70s-year-old guy, very sick on the transplant service. He was been admitted because he had a failing transplant on immunosuppression. He's got an IV infiltrate injury on his hand. So Nico, what do you think?
Yeah, I mean, this is probably a couple of days after, because usually they're just really swollen. What you have to find out is what they were infiltrating. If it was like a what was it, immunotransplant, right?
Yeah, it was. They think it was one of the cytotoxic agents.
Yeah. So I don't remember exactly like how to. There's a table, so you could look it up, and what you could actually counter whatever they're using.
Yeah, and let's just say that the time frame now, as you already correctly stated, we're a couple days into it, so anything you can inject is not going to really help. Yep. So now we have this kind of what you're seeing here, this wound.
Yeah. So if you get to this point. The skin, I don't like to leave eschar because I feel like there's stuff hiding under, especially in someone who's immunocompromised. They're not going to really mount a white count. And so if you see eschar, you have to actually debride it. You have to see if there's infection underneath.
So you'd be pretty aggressive.
Pretty aggressive.
Yeah. Anything different, Tony or Kevin? So you're going to go to the OR. So you go to the OR, and this is still with the ortho team debrides it, and I'm getting involved kind of at the top left here, and they're debriding it, and this is where we're at now. What are your thoughts? I know, Tony, what do you think about the wound now?
I mean, now you're staring at a critical defect with exposed tendons, so it needs some sort of soft tissue coverage. The tendons are intact or not?
They're intact.
Okay.
Probably not a lot of peritoneum left there.
Sure. Yeah. I mean, then I also consider the other factors that are going on, the comorbidities, as well as the agent itself and the health of the wound bed. If it was a cytotoxic one, or if he's very ill, or on immunosuppression, I'd be concerned about whether or not even some sort of dermal substitute would even work, even if he can granulate into that wound. Period.
Good thought. And so the transplant team at this point is getting nervous, and so we're at the bottom there photo. They're saying, "Okay, can you guys just cover this now? Is it ready for coverage?" Nico, do you think you're ready for soft tissue coverage at this point?
No, I think you have to. When you debride, you have to debride it like cancer. So you have to debride. You do the debridement, and you worry about the reconstruction. I mean, it's always in the back of your head, but you can't think that you could cut corners to do a smaller reconstruction. You have to debride it to where you have like a stable wound.
Spoken like a plastic surgeon. I love that.
What you don't like on this picture? Is the wound bad?
Yeah, the wound bed it's not ready for reconstruction. And some of the things we talk about in reconstructive surgery is, the failures that we see in reconstructive surgery are largely due to inadequate debridement. So the point I was getting at. So I guess the other question I would have for you guys is, how often would you take this to the OR, Nico? You see that top picture and the bottom picture. How often are you debriding this, and what kind of wound care are you doing in the interim?
Yeah, the one if the patient is kind of like sick, I would probably go every other day, like every day. So, but then they're like relatively stable, and then just based on OR time, every other day. So the one on the left, I'll probably go the next day, right? But I think in terms of wound care, I would probably use, like if you're going every other day, I probably use like a wound vac. I also want to keep the tendons sort of, I don't want them to desiccate. So I would use like a Adaptic and then put a wound vac on top.
Yeah, good. And I think the white sponge.
White sponge.
Yeah, the white sponge. Yeah, good comment, Trig. It's interesting because what I can't. This was very aggressive, and it was very difficult co-managing this patient with ortho. We didn't really, and this is over a week into it, and we were kind of getting really nervous about just the progression of this wound. But I think to Nico's point, we really had to debride this like a cancer. I mean, we had to really be aggressive with debridement. So now we're getting kind of close, and this is the defect that we're looking at. So say now we're happy. Tony and I trained at the same place with a wonderful mentor. What's your reconstructive ladder here? And keep in mind, again, this is and the thing with me, I do a lot of microsurgery, but keep in mind this is a very sick guy who is immunosuppressed, and we have limited options. So what are we thinking?
Yeah, so you have to at least do some sort of skin substitute. This is not something that's going to granulate in. There's exposed tendon, no peritoneum on top. So that is the very bare minimum that you may be considering in someone who is like sick, unhealthy, debilitated, and not really using their hand all that much. But I think, that is the bare minimum. I think that you'll probably have to go up higher. You're going to have to think about some sort of pedicled flap or free flap, what have you, once you get back to stable wound edges.
So, Kat, obviously I don't do any of this, but is the volar forearm rotation, can you rotate that instead of like free flap into this?
So like a pedicled, so you can kind of see the bulla on his arm right there at the thing. He had very horrible skin all the way up to his elbow, very thin, very friable skin. So to Dr. Candemere's point, thinking like a radial forearm flap that we use a lot in surgery, like to rotate it. He also had poor inflow, another thing, to his hand as well. So besides skin substitutes, anything else would you consider?
Actually, I have a question about debridement. I know for like open fractures, we usually don't take cultures, but would you culture this? Because of immunosuppression, and a lot of times they could get like fungal infections and.
That's a great question, because if you go back here, I mean, honestly, the one thought I had is some type of a necrotizing infection in a transplant patient, and we sent numerous cultures with nothing significant return. And he was on broad spectrum antibiotics at the time, obviously, to control whatever, but nothing grew up from the cultures. So this is where we're at. So, so I think Tony brought up skin substitute, good idea. Would anybody just put a skin graft on this?
I think it depends on what the goal of care is. If he's like really sick and he just wants a coverage, then you do the simplest thing you can, even though the tendons might not move. If you could do a free flap, but doesn't mean that's the right choice for this patient, because if he's really sick, right?
Yeah.
There are. Maybe you could tell me more about this, but for me, like Integra has always like socked down the tissue, and so they don't really move that well. I've used something called Stravix in the past, and then I get to move them right away, and that's actually worked pretty well. I have a case kind of like this, not as sick as him, where I put the Stravix and I have the patient move. It took close to 10 weeks, but then I didn't even have to skin graft. It just kind of healed by itself.
Yeah, and I've heard that about Stravix. I have a pretty big history with Integra, and I'm not picking any, I think there's a lot of different bilayers out there, but I tend to use the Integra bilayer.
You can move them right away, right? Integra, or you have to
That's a good question. I mean, usually, like in this kind of a case, if we used Integra, we'll see. But I think, I'd use but whatever the collagen du jour you want to use, I'd probably vac it for 5 to 7 days in a splint, and then start moving it after 7 days.
Okay.
So you guys called it right. I mean, he was so sick, and I think that, again, my practice has largely been microsurgery over the years, and I think we just could not justify, as Nico said, doing a big flap on this guy, and it was kind of a Hail Mary. I said, well, we'll try Integra, a collagen membrane. This is a bilayer collagen membrane, and I put Integra on there. We kind of talked about this, but you've used. So what's your protocol like in this type of a case? How long would you put on there? Would you vac it, or how long do you vac them for?
So for Integra, or just like?
Just any skin substitute.
Yeah, so the reason, because I got like some conflicting information for Integra, because I thought you couldn't move them for a while, and then until you skin grafted, but then one of the reps told me that you could move them. And so I actually went to Stravix, because the Stravix rep told me that you could actually move them right away. And so when I put the Stravix, I actually put them in a volar splint and have them move their fingers right, like from time 0.
Yeah, I'm not sure there'd be a difference actually between the two collagen membranes that move them or not. But in this case, yes. So I put this on. We do a, it's funny because the one thing about a collagen membrane and a vac with these tendons, I mean, after the first couple vac changes, I was not convinced that this was going to be, a good option. I thought the coverage over the tendons wouldn't be good because there was no peritoneum. And you can see again, I couldn't find his function slide. He had good flexion, but a significant extensor lag with his hand. But we got stable coverage, and and he was very happy. And I, honestly, I had no idea that this would actually work, but good coverage plan.
Yeah.
Do we have time to do another quick one? This is kind of another, it's more complicated one. Again, Dr. Immerman sent me over this case of a patient who had a million medical problems. As you can see, he had a carpal tunnel release at another facility, infection, abscess, IND several times. He's got an incomplete arch in his hand. He's had everything tried and nothing has worked. So this was a tour de force here as well. So small wound, but a very difficult problem. I don't know, Tony, what do you think? And you can see actually the biologic membrane that failed. That was my advice to Igor. He called me and he said, "What do you think?" I said, "Let's throw. I have so much success. Throw a biologic membrane on there, and that's the failed biologic membrane." So now I've given him my one bright idea, and it's failed.
Yeah, I mean, you're sort of stuck in a corner at this point because you sort of worked your way up this ladder, and sort of like your last conservative rung has sort of failed on you. So. And also, sick guy and his incomplete arch does make you concerned about some of the easier options, like a radial forearm. Right,
and we thought about everything. I mean, we scratched our head, and this is. I mean, Nico, what do you think? So, what are some options here that you can think of that this wound will not? I mean, the margins are indurated. It's horrible tissue. You can't close it, and he's got exposed tendon and nerve at the base of this open wound, and now we're probably at least 3 months out from his index carpal tunnel release.
Yeah, I guess you can't. Let me see. If you do, because he has an incomplete arch, right?
Yeah.
So you probably can't do like a radial form. I know that there's like the FCU perforated flap or something that you could do.
I'll cut to the chase. So this is what it looks like. So just to make it, so now we've tried everything. We've tried wound care. I think after the biologic membrane failed, I said, well, throw some fancy wound care on there, Igor. It'll get better with some time. And then these are the pictures I get. I'm getting hammer texted.
What is that? What is that growth?
It's just fibrinous gunk over top of his nerve and tendon. So the fun thing about plastic surgery is understanding the anatomy, and I got to give my partner, Mike Terry, who Nico works with a lot, credit for coming up thinking about, okay, how can we design a flap on the hand that doesn't take away his incomplete arch. So he's got flow through his ulnar artery. So we thought about using a perforator flap, and so basically we kind of make this up because you go to textbooks and you can kind of see the ulnar artery perforator coming up to the skin flap in theory, which is going to keep this flap alive, right? So we Dopplered it out. It's got good flow. It's got good bleeding at the margins. And we rotate it over, and we're able to get the wound covered. And I guess I skipped the middle part where the flap was completely congested for the first 5 days after surgery. It looked horrible, and we thought it was going to die, and it actually made it. So this was a Hail Mary, and this was a head scratcher because honestly, I've been doing this for 20 years, and I've covered a lot of holes, and this was small in a horrible area in a bad patient with comorbidities, and we had no idea how to cover it. So kind of a good save there. Oh yeah, I did put the bad picture in. So yeah, so it's so this is like in clinic, and I thought for sure that it's in plastic surgery, the part of the flap that dies is the part of the flap that you need the most. That's the rule that we have in plastic surgery. So I think that's it. I have more cases, but I think that's where.
Yeah, I think we're in between them and happy hour, and so.
All right. Thanks everybody.
Thank you for your attention.